made my talk a little bit easier, has covered quite a lot of it already. So I will probably whiz through the slides, and then we can probably have some questions and discussion at the end. I could say there are a lot of trainees here, so I'll start with some sort of basic pathophysiology. As we all know, the blood glucose is maintained with a constant balance between the blood glucose utilization and the blood glucose production. And the blood glucose is used for various metabolic processes within the body. And the blood glucose comes from the diet. And if somebody is fasting, then they come from the breakdown of the glycogen or gluconeogenesis. And the whole process is tightly controlled by insulin and glucagon. And so to maintain normal blood glucose, someone should have an adequate substrate, intact enzyme system, and a normal endocrine system. So any problem with any of this would obviously lead to hypoglycemia. Why is so concerned about hypoglycemia? Because we know that low blood glucose can cause brain damage, and the studies have clearly shown, especially in patients with hyperinsulinism, that significant proportion of them, regardless of whether it's a transient or a persistent hyperinsulinism, the hypoglycemia in the neonatal period is the key issue, that it can lead to brain damage. Sometimes it may not necessarily be a gross sort of neurological damage. It could be subtle problems like visual disturbances or speech difficulties or cognition abilities. So that's why we have to be so careful in maintaining the blood glucose and the normal range in the newborn period. We all know the babies do drop blood glucose just after birth, but once they have the feed, the blood glucose come up, which is a very normal process. But in some babies, at-risk babies who are born early, or IUGR, perinatal hypoxia or sepsis, or certain syndromes, then they tend to have a prolonged hypoglycemia. And the typical example for the syndromes is a Beckwith-Wiedemann syndrome, which is quite rare, but can present with hypoglycemia and hyperinsulinism. And the other features of this syndrome is macrosomia, large tongue, ear creases, and organomegaly. And we had a patient who unfortunately developed a liver tumor as well as Wilms tumor within the first year of life, and had a severe diazoxide unresponsive CHAI as well. He subsequently had all the tumor removed, and the CHAI responded to octreotide, and he's currently now come off all treatment and he's doing quite well. So the definition is always a debated topic, but the thing to remember is not about just one number, blood glucose value. It's about how symptomatic the baby is, how unwell the baby is in the context of a low blood glucose and in the presence of the other risk factors. Now, historically, we have used this cutoff 2.6 or 45 milligram per deciliter. So that's generally what the neonatologist will be using. The PES recommendations are most babies should be able to maintain blood glucose more than 50 in the first 48 hours and more than 60 after 48 hours. But what we know for sure is in babies like hyperinsulinism, the insulin also suppresses the alternate fuels like ketones. We got to maintain a higher threshold and maintain the blood glucose above at least 65 milligram per deciliter. Now, in terms of the interventions in the neonatal period for low blood glucose, the AAP guidelines are available. There are a few other guidelines, BAPM guidelines available as well. So the neonatologist would generally tend to follow this. And again, that classifies patients into whether they're symptomatic or asymptomatic, or if they have risk factors or not. And I won't go into the details of all of this, but that's what the neonatologist will use to identify these patients. But in any patient who has severe hypoglycemia, or who has persistent or recurrent episodes of hypoglycemia within the first couple of days, then that got to be escalated to look into the metabolic and the endocrine causes of hypoglycemia. There are a number of causes, as mentioned before, and we will probably touch on some common causes which we are likely to see. Just to understand, like if somebody is undergoing fast, the first thing, obviously, the glucose gets used from the food, and the first metabolic process to happen is the glycogenolysis, where the glycogen in the liver and the muscle gets broken down and the glucose is released. The next step is the new glucose formed from breakdown of protein and fat. And the last thing to happen is the fatty acid oxidation, where the fat gets broken down and ketones gets released. And just an understanding would help to understand the etiology of hypoglycemia based on the duration after a fasting period. Now, the common causes we are likely to come across is hyperinsulinism, as you've already seen. Adrenal insufficiency can present with hypoglycemia. Among the inborn errors of metabolism, GST and MCAD, liver failure, we have seen patients with galactosemia, tyrosinemia presenting with hypoglycemia and hyperinsulinism. Idiopathic ketotic hypoglycemia is quite common in toddler age group, and rarely we might see patients with postprandial hypoglycemia, especially in patients with GI problems and who have got surgery. Now, the metabolic causes, these are the common sort of metabolic causes, but usually there will be other clues apart from hypoglycemia, like acidosis and the other ketosis and other features as well, to suggest that it's likely to be a metabolic problem rather than an endocrine issue. The investigations in that scenario, obviously, we would extend to include the metabolic investigations, including ammonia lactate, amino acids, urine organic acids, acylcarnitine, a blood gas, and then further genetic and enzyme testing. The symptoms could be very wide and variable. That's why we always say any unwell baby or a child, we got to check the blood glucose. And the signs when we are examining a baby with hypoglycemia, you look for macrosomia, dysmorphic features of hypopituitarism like jaundice or small phallus, midline defects, skin pigmentation, thinking about primary adrenal insufficiency, hepatomegaly, thinking of glycogen storage disorders, but also in hyperinsulinism, we can see mild to moderate hepatomegaly. Key investigations, again, we touched upon this before in the previous talk. So the crucial thing is to get the critical sample during the hypoglycemia, and the ones highlighted in red should be taken at the time of hypoglycemia, which will help us to make the diagnosis, including glucose, insulin, cortisol, fatty acids, and 3-hydroxybutyrate is the ketones we measure in the lab. Carnitine, acylcarnitine can be done at a later stage if you can't take it during the episode of hypoglycemia. Urine ketones would be useful, but more useful would be if there is a bedside ketone stick available, then that will be useful to give an instant sort of answer. If we miss and if we can't do a hyposcreen, then obviously we have to manage the patient by giving dextrose fluids, but a controlled hyposcreen can be taken later to draw the blood glucose when the blood glucose drops below a certain cutoff, and we can then look at all the hormones and the metabolic parameters to make a diagnosis. In select patients, we do investigations like prolonged glucose tolerance, protein load, and exercise test based on the suspected or the history of when the hypoglycemia happens. There are different approaches. The one we tend to follow is looking at the first thing, looking at whether it's ketotic or non-ketotic. So that's the main sort of key to understand whether we are in a ketotic state or not. If it is ketotic, then we look at, think of metabolic conditions like GST, gluconeogenesis defects, and also hormone problems like growth hormone deficiency, cortisol deficiency, and hypopituitarism. If there are no ketones detectable, then you look at the insulin. And if insulin is detectable, that's abnormal. During hypoglycemia, the insulin should be undetectable. So it doesn't have to be high. Any detectable insulin is abnormal. And that would suggest hyperinsulinism. If insulin is not detectable, then we go down this route of possible fatty acid oxidation defects in a non-ketotic situation. Now, if you've ruled out the common endocrine and metabolic problems, then in older children, then we are left with the idiopathic ketotic hypoglycemia. So I'm going to go through some patients, some may be quite common sort of scenarios. This is a term baby who was born and noted to have a male genitalia, but gonads were not felt at birth. The baby went home and came back after 2 weeks with electrolyte problem and hypoglycemia, and the genitalia looked abnormal. I'm pretty sure all of you would be now thinking of what the underlying diagnosis is likely to be here. So these investigations were undertaken, and this is a clear-cut sort of presentation of primary adrenal insufficiency. And in babies, that's most common cause is the CAH. And we know the common defect here is the 21-hydroxylase defect, leading to raised 17-OHP and virilization in an XX baby. The treatment includes fluid dextrose bolus and hydrocortisone, and also fluorocortisone and sodium supplements. The next patient is a baby who was born 36 weeks, noted to have a small phallus, and both testes were undescended, also had jaundice, and then was noted to have hypoglycemia. So at further investigations, here pituitary screen. So here we are, based on the clinical features, we are suspecting a hypopituitarism, and this patient was diagnosed with hypopituitarism. Again, the treatment is initial ABC and resuscitation. Now, when we diagnose with hypopituitarism, obviously we need to replace the pituitary hormones, and we always start the hydrocortisone first and give it for a couple of days and then stop thyroxine afterwards. One thing to remember is hydrocortisone can unmask a DI, so we look for the urine output closely once we have started these patients on the hydrocortisone. Growth hormone is something which will be needed then later on after first couple of years of life based on the growth in these patients. Next patient is a 3-year-old girl coming with an intercurrent illness, looking very drowsy, dehydrated, blood glucose is low. As you can see, the urine ketones here is 3+. And we know this is sort of typical scenario of ketotic hypoglycemia. The cortisol was normal and the hyposcreen was done and insulin was undetectable. And acetylcarnitine, urine organic acids were normal, ruling out fatty acid oxidation defects. And the blood glucose improved with IV dextrose in this patient, and subsequently the patient was sent home. So ketotic hypoglycemia, we know, is a common diagnosis, but rarely there could be an adrenal insufficiency or a metabolic problem presenting like ketotic hypoglycemia. That's why we got to be a little bit careful, because it's a diagnosis of exclusion. And the other problem is some of these patients could sometimes come back with repeated episodes of ketotic hypoglycemia. It could be classical, clear-cut ketotic, but they may come back quite repeated, and they may have a very limited fast tolerance, especially overnight. So that could be an issue. There are a small proportion of patients who have severe ketotic hypoglycemia without any underlying metabolic or endocrine cause for that. So when do we then suspect this could be something else rather than a standard ketotic hypoglycemia? So if they come back with repeated episodes, or if the ketones take a long time to clear from the blood, or if they have postprandial ketosis, or if the lactate is high, if they have hepatomegaly or short stature on examination, those should be pointers to an underlying metabolic problem. Moving on to the last case, this baby was born with a birth weight of 4.5 kilo and was noted to have severe hypoglycemia at birth. And this is similar to the case we discussed before. So hypoglycemia screen confirmed hyperinsulinism. As you can see, insulin levels were high, fatty acids and ketones are suppressed, and the cortisol was normal. The other thing also to mention here is because of the high insulin situation, cortisol could be low in these patients at the time of evaluation, but that's been well established phenomena. That doesn't mean they have cortisol deficiency. That could be because of the high insulin. So this baby was confirmed to have congenital hyperinsulinism. And as we saw, this is the commonest cause of recurrent or persistent hypoglycemia. And most of them do present in the neonatal period. But rarely we have seen patients coming a bit late or being diagnosed as epilepsy, and then subsequently blood glucose problem was identified and present a little later. By the time they would have had some neurological problems, unfortunately. Diagnosis is based on the glucose infusion rate. The normal requirement would be around 4 to 6. So if it escalates above 8 milligram per kilo per minute, that suggests a high insulin state, in combination with detectable insulin and suppressed fatty acids and ketones. The other thing, again, to remember, sometimes processing insulin can be a little bit tricky if the sample is not sent to the lab straight away. In those situations, sometimes we might see insulin being low as well, but it's a combination of features of needing high amount of glucose infusion with suppressed ketones and fatty acids, which would suggest a diagnosis of hyperinsulinism. A very high level of insulin doesn't mean it's a severe problem or persistent problem. And the key marker here is a high infusion rate, as you said before. I'm sure everyone knows how to calculate the glucose infusion rate. So once you made the diagnosis, then the next question is it going to be a transient problem or persistent? And if it is persistent, is it going to respond to diazoxide or not? So the first step in our management is to assess the diazoxide responsiveness. And patients with underlying risk factors like preterm or IUGR babies, or if mothers had certain medications like beta blockers or birth asphyxia or maternal diabetes, they usually tend to be transient hyperinsulinism, and especially in infant of diabetic mother, it tends to be very, very short-lived with it for a few days to maximum few weeks. But when we say transient, it can last on for a few months, and for practical purposes, if hyperinsulinism resolves in 12 to 18 months of time, then we call that as transient. Anything persisting beyond 18 months or 2 years, then we put them into the bracket of persistent hyperinsulinism. So coming back to our patients, so the hypoglycemia screen was done. Dextrose bolus was given to correct the hypoglycemia, and then the continuous dextrose infusion was started. Obviously, we can give up to 10 or 12.5% through peripheral access. Subsequently, then we need a center line. So this baby needed up to 25% dextrose, which gives a glucose requirement of 20 milligram per kilo per minute. Now, in this scenario, glucagon could come quite handy. So glucagon, standard glucagon, which we use for patients with diabetes, so the glucagon could be run as a continuous infusion, starting with a dose of 5 mics per kilo per hour, going up to 10 or 15 mics. Glucagon can be run through a peripheral cannula. It can run alongside the other fluids. So it could be a very useful medicine to take away the pressure from giving so much fluids, dextrose containing fluids, to tackle the hypoglycemia. If there is no IV access, obviously IM injection boluses can be given until we get an IV access. It can be also run as a continuous subcutaneous infusion as well, using a standard cannula. So stabilizing the blood glucose is the first thing to do, because diazoxide will take time to work. So we need to give enough dextrose fluids or glucagon to keep the blood glucose stable straight away. Then we start the diazoxide. It is an oral medication, so ideally we want the babies to be on at least some trophic feeds before we start diazoxide, so it's absorbed properly. And we know the diazoxide has certain side effects. The starting dose will be from 5 milligram per kilo per day up to maximum of 20 milligram per kilo per day, which is given in 3 divided doses. And because of the fluid retention side effects of diazoxide, we always use it with the diuretic. And if you're using high dose diazoxide, stronger diuretics like furosemide would be recommended. Always get an echocardiogram, because we know patients with underlying cardiac problem can end up in severe complications like pulmonary hypertension if they are started on diazoxide. So we got to be quite careful in cardiac patients before we start the diazoxide. And we reported this from a UK cohort from all the centers of the number of patients who developed pulmonary hypertension, some quite significantly unwell following diazoxide treatment. And the risk factors identified were either underlying cardiac problem or excessive fluid being given. So we restrict the fluid, including the feeds, to maximum of 140 mils per kilo per day in these patients when they're on diazoxide treatment. Once they respond to diazoxide, that's good news. Then we can discharge them home on diazoxide. We train the parents to monitor the blood glucose, give a clear plan to follow at home if what to do if the blood glucose drops. They can use a glucogel or give a feed. We don't routinely give IM glucagon only in those patients who have severe hypoglycemia or live far away from hospital or have difficulty accessing the ambulance. Then we train them for glucagon as well. But the key thing to do before they go home is to do a 6 to 8 hours safety fast, because on diazoxide, they should be able to fast like any other baby would normally fast for 6 hours. So to assure that will be key before they are sent home. Now, if they don't respond to diazoxide, then that's where we are in a difficult situation. Then we move on to the next level to follow the pathway of looking at the genetic test here. And the rapid genetic test can be done within a few days to a week or 2. And that will then help us to understand whether this is a diffuse disease or focal disease, as we again discussed in the previous case. And to understand that, I'll just show briefly about how the beta cell operates in terms of insulin release. Now, this is a glucose regulated process. If you all had nice sort of evening meal today, so your blood glucose level goes up, then that's the glucose is taken up into the beta cell, Krebs cycle, and then potassium gated channels with potassium exocytosis. The KATP channel closes, and that then leads to membrane depolarization, which opens the calcium channel, influx of calcium, and then insulin gets released. Now, the problem happens in patients with severe forms of hyperinsulinism. We are talking about patients who do not respond to diazoxide, who are likely to have underlying genetic etiology. And most of them do have a problem with this KATP channel, which got two subunits coded by KCNJ11 and ABCC8. A defect in any of these genes can lead to a problem with this channel, which is then constantly closed, pouring out insulin into the bloodstream, irrespective of the blood glucose level. Again, if the patients who have homozygous mutation obviously are very severe, the ones who have heterozygous mutation have partial defect and may respond to diazoxide. There are a number of other mutations, as we again discussed before. And what is interesting here is some of the genes here, you could see they also cause MODY, the maturity onset of diabetes in young, or the familial diabetes. So they also cause hypoglycemia on hyperinsulinism. Somebody asked a question about why we are asking history about diabetes or hypoglycemia in the family, and that is the reason we asked that history, because that could help us then to proceed with the genetic test, even in those patients who respond to diazoxide. Because HNF4 alpha 1 alpha, the babies will respond to diazoxide quite well, but only when you dig out the history, then you'll understand there's something sort of quite an extensive diabetes history in the family. FOXA2 is a gene we described from our unit following a whole exome sequencing study, which is noted to cause both hyperinsulinism and hypopituitarism. There are a few rare forms of hyperinsulinism. Now, if you see a high ammonia level in a patient with hyperinsulinism, then this suggests HIHA syndrome, which is hyperinsulinism, hyperammonemia. These patients have fasting hypoglycemia as well as hypoglycemia after a protein-containing meal. So they have postprandial hypoglycemia. So generally for our patients, we will suggest checking the blood glucose before meal. But in this group of patients, we will suggest checking the blood glucose 1 or 2 hours after meal as well. And these patients can have neurological problems like epilepsy. And fortunately, they are all diazoxide responsive. And we have even seen one patient who actually managed to come off the diazoxide and currently doing absolutely well without any treatment. She's now like 15 or 16 years old. So that's HIHA. HNF4 alpha 1 alpha we mentioned before, so they cause the diabetes in the adults and hypoglycemia, hyperinsulinism in the babies. The babies are quite big babies. Again, that could be a clue towards this genetic mutation. And they respond to diazoxide and they usually come off treatment by 6 or 7 years of age. But subsequently, then they have the risk of developing diabetes as an adult. Now, that could happen after 15 years, 20 years, 30 years of life. It's difficult to predict, but we do monitor these patients with an yearly HbA1c and alert them about the symptoms of diabetes. HNF1 alpha has been very recently described from our unit. And again, we have reported a diagenic mutation where in the same patient who was noted to have both ABCC8 mutation and HNF4 alpha mutation. And what was interesting is this patient still responded to diazoxide, maximum dose of diazoxide, and is been doing well. So I think probably this patient HNF4 alpha mutation was much more severe than the ABCC8 in this particular patient. So there's a number of different subtypes within the hyperinsulinism, as we just discussed, ranging from mild. The dominant or the heterozygous patients tend to be mild, whereas the recessive or homozygous or compound heterozygous patients tend to have a severe form of hyperinsulinism. Histological subtypes: diffuse, where the whole pancreas is involved, and focal, where there is an area of hyperplasia within a small area of the pancreas. Now, the focal disease is distinct from insulinoma. Insulinoma is a benign tumor, which is more common in adolescents or adults, could be part of MEN, whereas a focal disease is not a tumor, it's a hyperplasia within a part of pancreas. And the genetics, again, if you get a homozygous or a compound heterozygous patients or heterozygous who respond to diazoxide, they generally indicate a diffuse hyperinsulinism. The ones who do not respond to diazoxide and who have typically a paternal ABCC8 or KCNJ11 mutation, then they have generally are likely to have a focal lesion. And Doppler PETs can be discussed before, and that will help us to identify the location in this patient. The uptake is more here in the head of the pancreas, and that indicates a focal lesion in the head of the pancreas. And this patient, the uptake you can see that's uniform throughout the pancreas, suggesting a diffuse disease. Now, if the genetics suggest a diffuse disease, we don't have to do the PET scan because we know that's most likely diffuse, and we move along the next step of treatment, basically. So the medical management for our diffuse patients, second-line octreotide is given as 6 to 8 hourly subcut injections. It can be used as a continuous infusion through a pump to go home. Usually they will need a high calorie or continuous feeds alongside the octreotide to get the blood glucose under control. Now, the problem with octreotide, they initially respond well, but subsequently the response tends to come down because of the tachyphylaxis. And these are other side effects we need to monitor, like growth, thyroid function, and cholestasis. Necrotizing enterocolitis has been reported in sick newborn babies who have been started on octreotides. Again, we got to be quite careful in starting this in babies at a very early stage. There are some of the other new treatments, again, as Lokesh mentioned before, they are in pipeline. I will probably mention a couple of them. I mean, long-acting somatostatin analog are much more well-established now. There are two preparations available. The one we tend to use here is the lanreotide, and the one available elsewhere is the sandostatin LAR. They come in different strengths, and the doses are slightly different, but generally the effect lasts for 4 weeks. So instead of giving few injections a day, we can manage these patients with one injection given every 4 weeks. And the dose for lanreotide is starting anything from 30 milligram. And we have started these patients quite early on. Now, we had a patient recently who was started on this at 2 months of age and has actually responded quite well to the lanreotide. And the sandostatin LAR dose will be from 10 milligrams. And this is for patients who do not respond to diazoxide or who respond to octreotide injections. Then it becomes useful to switch them to the monthly injection. And we monitor the parameters when they're on the lanreotide treatment. Now, pasireotide has been discussed, and probably some studies are going to come out. And there's a lot of advantages here that specifically inhibits the insulin secretion and doesn't affect the glucagon secretion. But it's probably going to be a long way before we get into the practical use of pasireotide. We discussed mTOR inhibitors before, so we reported that for the first time a few years ago, and noted it to be effective in a small number of patients who managed to, respond well, and it stopped them from going for the neonatal pancreatectomy. But as Lokesh showed, there has been more studies subsequently, and the fact all patients may not respond to sirolimus. The response could be variable depending on the mutation. It may have to be combined with octreotide or lanreotide. We got some patients with that combination who respond well. But one thing to remember is sirolimus is an immunosuppressant. It can cause infections and sepsis. Fortunately, we haven't seen that much, but it has been noted elsewhere. And so it has to be used very, very, very carefully in only select patients with very clear instructions to parents about the risk of infection in these patients. Exendin has been studied at an early stage, but these studies, again, it could be a useful drug, but hasn't sort of studied further to roll it into sort of clinical use. Insulin receptor antibodies, the studies are undergoing for quite some time. So hopefully that could be another option. But again, there are concerns about using insulin receptor antibodies as well. This was mentioned again, the soluble glucagon. So the glucagon which we currently have is not stable to be used as a continuous infusion in the pump. So the new soluble glucagons are coming up in a big way. You might have obviously noted that in patients with diabetes, it's coming up, and also in bionic pancreas, it's being used sort of dual insulin and glucagon therapy in diabetes patients. So the same glucagon, which is stable, is being tried in patients with hyperinsulinism. We are one of the global centers part of this dasiglucagon trial at the moment, and they have moved on to the extended phase now. So hopefully this would come up as another option for severe patients so that they don't have to end up in surgery. that's about the glucagon. And if nothing works, then for the diffuse patients, then they will have to have the neonatal pancreatectomy, which is not an ideal treatment, but sometimes that may be the only option we have. So once they have the surgery, they can be stable for some time. Some tend to have hyperglycemia straight away after the surgery, but which may settle down. But some may have persistent hypoglycemia needing second surgery as well. But what has been noted in the long-term studies is that invariably they all tend to develop diabetes in the long run. So the surgeons will leave a small pot of pancreas to produce just enough insulin to keep the blood glucose stable. But the problem is that small pot can burn out over a period of time, leading to diabetes at a later stage. So just to summarize then, hyperinsulinism, diazoxide is our first line of treatment. If they don't respond, then we do genetic tests at that stage. Top-up PET scan is useful, and surgery for select patients. And there are newer medical options coming up for diffuse patients. The family support group, certainly you can direct your patients to this website, Congenital Hyperinsulinism International, which is based in America, but they're quite global, and they try to help the families and answer individual queries. And they do run a number of educational events as well for families and professionals as well. The UK Children's Hyperinsulinism Charity also are contactable, and they have social media presence as well. This is our hyperinsulinism team within our hospital. Recently, we have been recognized as one of the 6 global centers of excellence for managing hyperinsulinism, 2 in UK, 2 in Germany, and 2 in America. So we're pleased to have received that recognition. So we have a team of like dietitian, psychologist, speech and language therapist, and nurse specialist looking after these patients. I just want to finish here also just by mentioning that we are organizing our British Society of Pediatric Endocrine and Diabetes conference this November as a virtual meetings, which would enable people to attend from anywhere. So if anyone is interested, please do have a look at the EBSPD website. The program is available and the registration process has started as well. So we'll look forward to seeing you many as part of the EBSPD conference in November. Thank you very much.
Thank you, Dr. Senthil, for that wonderful talk. Now I think we will take up questions. Dr. Subrato and Lokesh. Yeah, and I think we will require Senthil's inputs also for many questions. Thank you, Dr. Senthil. And I also would like to just share here, we will not be having Dr. Khalid's talk today. Unfortunately, because of some personal reasons, he is not able to join us. So we will finish the questions and end the session. Thank you. Dr. Subrato, please.
Well, Dr. Senthil, that was an extraordinarily lucid and very, very comprehensive presentation. And I think I want to spend the next few minutes asking both Dr. Lokesh and have you on board to answer some of those difficult questions. The first question is to Dr. Lokesh is that sirolimus, which you use there in lieu of, subtotal pancreatectomy, near total, do you think that was the cause for the demise of the child later on? Is that, because that's a very serious problem, as you have shown in your wonderful presentation, in a vast majority of patients, and it cannot be taken as a given or as a substitute of surgery in a diazoxide unresponsive, octreotide unresponsive child.
Yes, sir. Sir, this is quite possible. Actually, we were monitoring the child with the already laid down evidences, like we were seeing her for neutropenia, liver function, kidney functions, and she did not ever, she never had neutropenia. She had mild transaminitis initially, which resolved spontaneously. After that, she did not have any issues with all parameters, and she did not have common infection like stomatitis or sore throat. She never had, but she had 2 life-threatening infection episode, and probably it may be sirolimus may be contributing to that. I agree with that.
So the question, Dr. Senthil, those patients in your index NEJM article, did you have any chance of actually following them up to see what happened in the later period?
Those patients have been doing well. One of them is like, this we published 2014, and there's one I met the dad actually recently. There's like 7 or 8, and she's still doing well without any problem. I've got like the patient in the unit at the moment who is 6 or 7 years old on sirolimus, again doing fine, but again that they take extreme precautions to avoid any exposure to somebody with infections, and especially if they're going to school or nursery, it becomes quite tricky. Obviously, they should avoid live vaccinations, and they'll be constantly monitored, and we do all the blood counts and everything quite closely as well. So that is a risk, that is a problem. So they have to be made aware of that, and we got to be select the patients very mindfully about this as well. Just we can't be using right and left.
So Dr. Sendil, that paper which you have published, which actually Lokesh has quoted as the downsides of neopancreatectomy, where yourself, Dr. Khalid, are authors. Now, when your back is against the wall and the baby cannot leave the nursery, because whatever you're throwing at the baby, the sugars are not going up, and you have to wheel them to the theater. And that happened with me with one baby, the first one historically in Kolkata, where we had the pediatric surgeon was willing to operate, and that was a success. And we did a near total, and we did have to give octreotide for a few weeks, but then we could stop it by the time the baby was 6 months old. So what is your take on that in view of the current opinions in new literature?
Neonatal pancreatectomy has been done for quite a while now, and it's been like a standard treatment. And if the patients need it, then they need it. That's the end of it. The idea of trying alternative treatments or the newer treatments coming, hopefully with the lanreotide or with the glucagon, long-acting glucagon, hopefully the idea is the hyperinsulinism can get milder when the patient gets older. So if we somehow manage them for first 5, 8, 10 years, then hopefully they can preserve the pancreas. That is the idea of the whole sort of all this actually. But once you've done the surgery and we've taken it out, there's no option. Then they got to be on treatment for diabetes for lifelong.
There's a question here on the chat box about let me see that. It says, what is the treatment of gallstones due to octreotide? Should the dose be decreased? Dr. Sendil.
Yes, again, if that would be possible, then yes, it depends again how is it just a mild cholestasis or is something symptomatic gallstones. We'll discuss with our gastro colleagues, and if there are alternative treatment options, then we may have to switch, or we tend to use the deoxycholic acid in these patients. They will be started on that when they are noted to have the cholestasis or gallstones.
There's another question in the chat box. How early have you been able to stop diazoxide in a case of severe hyperinsulinism / hypoglycemia in a newborn period where the genetics was negative?
So if we stop, then that means basically it's a transient hyperinsulinism you're talking about, I presume. The severe ones are they're unlikely to respond or unlikely to stop soon. The ones which resolve very quickly we have seen is the infant of diabetic mothers, where we sometimes end up starting diazoxide, and then within like 5-6 days the blood glucose starts going up quite quickly, and then we end up weaning and stopping the diazoxide, and they resolve very quickly. So sometimes yes, it can be very short-lived for a week or 10 days.
What would you consider as transient hyperinsulinism? What is the cutoff on the upper limit? Is it 1 month, 3 months, 6 months, or a year?
In UK, we tend to use 18 months to 2 years. If anyone stopping treatment before that is transient, anyone persistent beyond that, then that's persistent CHAI. So that's the general practical approach we take from among all the centers. And the reason for that is because we don't routinely do genetics on all the patients who respond to diazoxide. And if they are persistent CHAI beyond 18 months or 2 years, that is one of the criteria for doing genetic test. So
is that you would wait that long for doing a genetic test, not say beyond 6 months if the child is, still requiring diazoxide?
Yeah, that's correct. The other thing about, like, stopping diazoxide by itself is a little bit, it depends how actively we are going to try and wean and stop. If you leave them on small dose of diazoxide, they can be doing fine. But whether do you let them outgrow the dose and that very small dose, then you stop and then do a fast and make sure they have resolved, or whether we start actively cutting down the dose, basically, because these patients are never going to have high blood glucose, so they will just have stable blood glucose. So either we let them outgrow or start reducing the dose slowly. So it's a bit of an arbitrary timeline. Some units might go a little bit aggressive and stop the diazoxide by 6-8 months. Some take a slightly different approach, and these patients might end up being on diazoxide for 12 or 18 months. But for genetic test, we follow that criteria. But there is a caveat. But if there are patients who can respond to diazoxide and can have underlying genetic, like HNO4 alpha or 1
Absolutely,
alpha.
yes.
And that is where the family history is crucial. But in most patients, we have had some family history. You will say, you will come to hear like father has diabetes, but then when you go and find a little bit more type 2 diabetes, they'll be like quite slim, and this is not looking right, actually, something not right. Then you do the genetics and you find these mutations, and that helps the parents to change the treatment as well.
Absolutely. Now, since India is the land of SGA, a lot of our babies are small for gestational age, IUGR, and we see transient hyperinsulinism in a large cohort of these. And they do very well on diazoxide for about 4 weeks to 8 weeks and can wean them off by just keeping the dose the same. And as the baby grows, they go below the 5 milligram per kilogram, and then we just stop it and they do fine.
Absolutely.
Now,
And that is the same experience we have seen as well. Sometimes we use even lower starting doses like 3 milligram per kilo per day in these SGA babies, because they respond beautifully to a very small dose of diazoxide.
Now, one question in the chat box is, if you have a index case of CHI, what about the father? If the father is also, as Lokesh had mentioned in this index case, was had a heterozygous mutation. Now, does it always indicate focal, or can you have diffuse disease with this?
Mostly focal, but they can be diffuse. But in those situations, usually the father will manifest the disease like a diabetes or something like that. They're unlikely to be asymptomatic. So that is where the clue would be. But if the father is completely normal, let us say, no glucose problem at all, and then it carries the heterozygous mutation, then that's most likely to be a focal hyperinsulinism.
Can you predict which mutations will call diffuse disease?
So the homozygous or the compound heterozygous or diffuse? Are you talking about the heterozygous one?
Heterozygous, yes, because I had a baby with a heterozygous mutation in the baby and the mother, and actually Dr. Radha was the one who did that from Dr. Mohan's lab. That was way back, about 4 years ago. Child is 4 years old, and she turned out to be diffuse disease, but was doing well, so we didn't operate.
So most maternally inherited heterozygous patients would be usually diffuse, but also for example, where we do our genetic test in Exeter, they have a large cohort of patients. They have done sequencing, thousands of patients so far. So if it's a known mutation, they can go back and see the phenotype from the other patients, and usually within the report, they will attach this particular mutation is being noted in other patients with diffuse and likely to respond to diazoxide. If it is a novel mutation, then obviously we have to go clinically based on the response.
So you can have diffuse mutation in diazoxide responsive patients as well.
Yes. Yeah.
Sir, may I add something?
Heterozygous. Very rarely we have seen homozygous responding to diazoxide as well.
Sir, may I add something? What Professor asked?
Sure, go ahead.
You asked that heterozygous mutations may have diffuse disease, sir, but that is autosomal dominant inheritance. Usually, if autosomal dominant inheritance is there, then they may have diffuse disease, and that is like very, very presentation from asymptomatic to mildly symptomatic to severely symptomatic. We were talking about the paternally heterozygous mutations. They were not autosomal dominant. They were monoallelic recessive mutations where there was loss of heterozygosity of the maternal gene. So they were autosomal recessive at the level of tissue, and they were not autosomal dominant. So autosomal dominant may be diffuse, may have diffuse disease in heterozygous mutations. Am I?
Yeah, that's absolutely correct. So in the focal patients, there is second hit which happens within the lesion, within the pancreas. You're right. So that they become actually homozygous within that particular lesion. But that only we will know once we take the tissue out, and then if we do the sequencing, then we will know that.
I'll invite Dr. Radha, if you may, with a permission of Dr. Shala, if she can share a little comment about her CHI. She spoke about the neonatal diabetes, a little bit about her CHI experience. Dr. Radha, wonderful to meet up with you.
Thank you. So we have a lot of more of diazoxide unresponsive, obviously, than diazoxide responsive, and number of them are ABCC8 mutations followed by KCNJ11, GLUD, etc. But we have had quite a few cases of compound heterozygous and homozygous in the case of diffuse rather than plain heterozygous. So that has been our experience as far as the mutation has been.
Compound heterozygous, is that right?
Yes, compound.
Yes. And the parents, did they have?
Yes.
Both parents had one or the other?
Both, yes, each one contributing one.
Shala, some comments from you, please.
Pardon?
This is to Dr. Shala, if she wants to discuss something.
Dr. Senthil.
There are better experts than me here.
No, you can ask your questions. That's what I meant.
No. There are enough questions, and actually we are running out of time also.
So I think we have covered most of the things. And I really appreciate Dr. Shala and her team for setting this up. And I must end on this note that Lokesh, you did a wonderful job. Okay, it made sense.
I just have one question to Dr. Senthil. And when do you do partial pancreatectomy often?
No, Dr. Radha, that's not something we do actually. I know in some places where the difficulty in getting scanned, then people go ahead with the partial pancreatectomy, but we don't do that here.
What about that subtotal pancreatectomy which Lokesh showed? That is something was not there in Sperling's 4th edition, but he claims this is in the 5th edition, which I have to acquire. I don't have it. But subtotal pancreatectomy is neither here nor there.
Probably mention here total.
I think so.
There's a question.
Yeah, there are only 2 questions. I think they are from a very long time. They are in the chat. One is by Dr. Kavitha Babu. He's asking that what is regarding the histological classification of congenital hyperinsulinism, how to diagnose it, and what is the major imaging technique generally used for, particularly in India, if anyone can comment on that. And the next question is also, I just go ahead with this just to save some time, that what are the chances of relapse after stopping diazoxide? If so, how do we explain the pathophysiology? So I think these are the 2 important questions which I thought we should answer, and then we can close the section.
So yeah, sure, thank you. Histology is based on the histological sections after the surgery, but again, genetics initially can give a clue towards diffuse or focal. In terms of the scan, we have PET scan, but we do have ourselves sometimes difficulties with getting the dye as well. So it's not easy, but I presume DOPA is available in parts of India. So
it is. In fact, Bangalore, it is very, very routinely being done. CMC Vellore has DOTA scan, and I think Shala will be able to say more about any other centers that have come up in Bangalore. But certainly we have, in these cases, transported them to, and they're extremely efficient. Anybody wants, I can share their address, and that I got from Dr. Raghupati, who I was hoping would be in this meeting today. But yes, it can be done, and that algorithm which showed that diazoxide unresponsive, you must get them studied. We follow that to a T.
That's really good to know that. And to answer the second question, I think I think once patients are transient, we are probably talking about the ones who do not have genetic mutation. Once they are transient and they're resolved, we always undertake a age-appropriate fast that can be like 12, 14 hours, 16 hours to make sure the blood glucose is normal. Once they have gone through that, it's very unlikely for the hyperinsulinism to come back. So we tell them, now it's done and dusted, hyperinsulinism is resolved. But they will have a slight risk of ketotic hypoglycemia, like many other patients have, but that's not hyperinsulinism coming back. So that's something we reassure them very clearly. There's also another question here, how frequently we do echo for patients on diazoxide. I think if the first echocardiogram is normal, then there is no need to keep repeating the echo. But if the first scan picks up some cardiac defect, then of course, then they will need follow-up from that perspective.
So what about the gallium nucleotide that you use for scanning, imaging? Is that being used regularly?
I have no experience. We don't use it here, so I have no personal experience of using the gallium actually.
Okay.